Are you recording? The recording button is the hardest thing to remember. What does acetyl-CoA carboxylase do? Moving CO2. So this is a guy that has to deal with activating acetyl-CoA to malonyl-CoA, which then goes to form fatty acids. Okay? That's a function of this guy. So this does not happen in the mitochondrial cytosol. What ends up happening is that you take citrate, you pump it out of the mitochondria into the extracellular space, or the cytosol, I guess just to say, my bad. And then this then turns into acetyl-CoA to then get activated in this process. Okay? So this happens in the cytosol, not the mitochondria. But good attempt on it. Okay, so let's keep going. What cofactors is needed for this? That's a great question. What cofactors? Yes, perfect. A, B, C, with B being biotin. Okay, vitamin B7. Good. Good. What else could I ask you? What other enzyme? Yes, good. Biotin for all carboxylases. That was the next question I was about to say. What's another enzyme? You guys are good. All right, now here's question 20. This was another one that kind of threw people off. And I think it was because they weren't sure about the time span on when you're no longer having glycogen and you have to now form glucose. Okay. So 18 hours. Okay. Majority of your glycogen is gone around 16 hours. This is if you're not exercising. Okay. Now, with that being said, that means a majority of the time, you and me are eating glycogen. We're using glycogen. We hardly ever use fat. The only time you use fat is this. If you eat and you wait about an hour so your body can store the glycogen, and then you exercise right after, burning the glycogen, then the remaining 4 hours, you're using fat. And this is a educational tool that physicians use to try to help patients lose fat and lose weight. Because now you're focusing on using to burning fat versus burning glycogen throughout the rest of the day. Okay. And that's the key. That and then portion sizing and all that stuff. But anyways, so that's why this ends up being gluconeogenesis, because you're no longer able to use glycogen. This is gone. Okay. Good. Now, next question. This is a foundation question, and they're talking about what's the most likely to happen if you do a mutation from an A to G to C to G. So there's a splice site setup, which is known as GWOG. Okay. GUAG. Okay? This is required for you to properly undergo splicing at a location. What's the function of splicing? What does splicing do? Yes, so it allows you to remove the introns from the mRNA. Okay? So the only thing you have left is the exons, which then become the protein. Okay? I've even seen questions where they show you an image that looks like this. And then they ask you, what the heck is this? These are those introns that have been spliced out of this guy, which is the actual now mRNA. Okay? This is another way that they can throw it at you. Any questions on that? Okay, good. Now, here, this is once again an embryo question or EndoRepro, and it's essentially just saying what part of the placenta is the mom? What part of the placenta is the baby? Okay, so the chorion is baby. That's all baby. Decidua is all mom. Okay, which is why this ends up being Decidua basalis. Chorion is baby. Decidua is mom. Okay, so this question here is essentially what we discussed when we did EndoRepro. Because they're saying at what of the following times after fertilization did separation of embryos most likely occur? Well, what do we have? We have one gestational sac with two embryos. So this is monoamniotic. Monoamniotic, monochorionic. Okay. One amniotic space with one placenta. Which is why this ends up being this. Remember, you start at 6, it sticks on 6. So on 6, you are set up as diamniotic monochorionic. Then, as you get closer, it becomes monoamniotic monochorionic. This 6 is a good way to remember because once again, it sticks on 6. Now, if it's before 6 days, what is it? If it's before 6 days, what is it? 2. So at 6, you have the amniotic, monochorionic. So what do you have before 6 days? It's dichorionic and diamniotic. Okay? Any questions on any of that? Yes, because before 6, you're around like 1 to 3 days. Because this is 6 days. Mm-hmm. Okay. Good, good. Let's keep moving. Yes. Mono di. Perfect. Okay. So here we have the breakdown of neuro now. So now this is more of a neuro question again. And they're asking us what type of presentation is most likely to occur as a result. So this patient has a carotid sheath damaging the posterior portion of it. Behind the carotid sheath, you have your sympathetics. Okay. You have something called the stellate ganglion. So, with that being said, which one of these makes sense is A. What other symptom would you present with if you damage the sympathetics to the face other than meiosis? So ptosis, perfect, and anhidrosis, right? This is Horner syndrome. Okay, that's what they're hinting at here. Now, in this case, in 30, what they're essentially saying is, hey, this patient has an enzyme missing, PNMT. Can you tell me what stimulates this? B12. No. This is our lovely cortisol enzyme that we talked about earlier, how cortisol affects catecholamines. Okay. So cortisol stimulates this guy, which then increases catecholamines. Now, with that being said, they're then saying, well, what's going to happen if you lose this guy? Well, this guy is responsible for forming norepinephrine into epinephrine. Now, since we talked about cofactors, because I see B12, can you tell me what is the cofactor for PNMT? What's the cofactor for PNMT? This cofactor is known as SAM. Now, this is where your B12 can come into play because B12 is a big player that attaches methionine, Okay, changes homocysteine to methionine. And methionine then forms a whole bunch of other things by adding methyl groups. So B12 is a component of it, but it's not the main thing that's stimulating this enzyme. Okay, cortisol is the guy that's doing that. I hope that answers your question. Okay, perfect. Yes. Yes, exactly. Methionine is a big methyl donator. Okay, let's go keep moving on. 31. In 31, they have a scenario where they're saying, hey, we've dyed this DNA. Okay. And then we watched the DNA content in these cells. So then you have to think, well, what cells did you dye? You dyed neurons. My question to you is this: do neurons divide? No, never. They are known as permanent cells. So now my next question is this: in the cell cycle, where are these guys located at? So you got different parts to the cell cycle. You got G0, you have G1, you have S, you have G2, and then finally M, mitosis, which has the prophase, metaphase, anaphase, and telophase. So permanent cells remain in G0. Labile cells remain in G1. Labile cells are things like your stomach lining, your skin, any type of epithelial cell. Okay. Now, then you have another cell that starts in G0 but can turn into G1 when needed. These are known as stable or quiescent cells. These examples of this is what? Give me an example of something that can be permanent, but then become activated when needed. Stem cells. So stem cells are always in G1. We're thinking of things like hepatic sites. Okay. We're thinking of things like the proximal convoluted tubule. Okay. These are areas that get damaged and then all of a sudden can become regenerative. But they are not regenerative at the beginning. Your liver isn't just constantly growing, right? It's not until it gets damaged does it then start to divide. Okay. Good. Now, with that being said, make sure you don't forget about these guys. Okay? Your cyclins that stimulate CDKs 4 and 6. Which then allows you to bypass that first hurdle and enter into S. So surface lining cells, those are G1. They're epithelial cells. So they're constantly dividing. Okay. And yes, so given that scenario, that now we know that they're permanent cells and they're never dividing, you're always going to have 2n, never 4n, because 4n is whenever you've passed S phase. You've duplicated your chromosomal number and you're now getting ready to split. Okay? So that's why the answer to this is A, not any of the others. Any questions on this? This is a confusing foundational question, but it's still very important. Remembering your cell cycle, remembering the aspects of permanent versus labile versus stable cells. Okay. Now, the rest of these were pretty good. This was pretty much a throwback to what we did yesterday, right? You go head to toes, or head to heart, my bad, head to heart. And that's how you do it. 1 and 2. This is all portions of the inner ear. 1 kind of does it, but inner ear. Then you go once again with 2, which is once again the inner ear. 3 is a portion that does contribute to the brain, but 3 and 4 is the key. This is the carotid, the internal carotid, and the arch. Because after 4 becomes 6, and 6 is those pulmonary arteries. Okay, so that's why this answer is C. Now, this one was a complex one, especially if you didn't know how to approach it. Whenever you come across a neural question that has you trying to figure out where the location of the lesion is, you have to then depict, right? Is this in the spinal cord? Is this in the brain stem? Is this in the brain? So let's read this and figure this out. So 70-year-old man with history of diabetes and hypertension. Okay, acute sudden onset ataxia, hoarseness, and difficulty swallowing. Okay, I'm not sure, but acute makes me think that this is most likely a blood vessel issue. 2 days ago, he says that he felt the room was spinning. So this is making me think vertigo. So maybe brainstem related. When he fell to the ground and was unable to ambulate because of weakness and lack of coordination. 1 day ago, he developed trouble swallowing food and a hoarse voice. Okay. Shows anisocoria. So anisocoria means one pupil is not the same as the other. Okay. Which is what you see here. Left pupil constricted relative to the right. Okay. Decreased elevation of the palate. Oh, yeah, we are definitely in the brainstem here. Temperature and pain prick are reduced on the left side of the face. Okay. And on the right side of the body. Oh, okay. So we're now thinking, once again, we're inside the brainstem. Because whenever you have face one side, body the other, you got to think brainstem. Because spinal cord only does body. Brain only does the opposite side for the whole thing. Only brainstem does face one side, body opposite. Only brainstem does that. Okay? And the reason why is because facial sensation is ipsilateral, while body sensation is contralateral. And that's why it presents itself as one side is messed up, but the other side of the body is messed up. Okay. So it looks more like this. Like here's the head, and then here's my body and the legs. Right? So if you have a brainstem issue and it's affecting the sensory, one side of the face, and the body is the opposite side. Only happens in the brainstem. Okay? Because if this was a spinal cord issue, then you would have just the body. Okay? If you have a brain issue, it's on the same side. So this sensory innervation is a big clue to help you pick out where you're at. All right. Now, let's continue. So we're thinking we're in the brainstem, and we're confirmed because this is a cranial nerve here. So now, where are we at? Are we in the pons? Are we in the midbrain? Or are we in the medulla? This is when you have to look at cranial nerves to help to figure this out. Since we have vertigo, we're thinking this is cranial nerve 8. Okay? Now, let's keep going. Now, this could also be a cerebellar issue, like one of you guys have said, which is great. That is a possibility. But the palate issue is only a medulla. So now we're in the medulla, but we don't know, is it lateral or is this medial? This is where you then have to remember how your cranial nerves in the medulla are divisible by 4. So cranial nerve 12 is in the middle. 11, no. 10, no. 9, no. So now that's it. So it's not a midline damage, it's a lateral damage, which is why the answer is B. Now, I know this is medulla because this structure right here is what? What is that? This is the inferior olive. The inferior olive always looks like that. Okay. Once again, the inferior olive, inferior olive. This is the pons. And I know this is the pons because you see these lines going side to side. That's indicative of pons. Okay. Now, we keep going down. When you get to the midbrain, you see these guys, which is the red nucleus. So that's how you can figure out midbrain location if they're showing an image versus pons location versus medulla location. Okay? Any other questions moving forward? Good? Nice. Now, let's see here. That was the end of it. The rest of these everyone did fairly well on. I'm gonna leave the quiz up until later today, and then I'll close it like I did last time. Sound good? All right. So that's all of that. Ooh, you guys have now gone through everything that's on your test. Hearsay, there say, except for GI and biostats. Okay? In GI and biostats, there's not much you have to worry about. I'm going to show you guys the big things, but before, let's do some biostat questions. Okay? So this is the first question. I want you guys to take the time, calculate this out. I'll give you guys 3 minutes to figure it out. And then I want you to put your answer down. Can we keep annotation? Yeah. I'm going to send this annotation to you guys. I'll send the writing in it. Oh, do you want me to send the answer sheet to you? With the annotations? Maybe that's what you're meaning. This sheet? Oh, okay. Here, let me export this. Okay. There we go. And then I'll post it in the chat box. Thank you for bringing that up. Okay, so here we go. Here's this, and I'm going to post that in the chat box while you guys do this question. Okay, so I have that up there now. Whenever you guys are ready now, you can put your answers in. Okay, we have an A. Okay, so let's talk this through. So what's going on here is they want you to determine the impact on the result of the screening test. So whenever you think of screening tests, you got different parameters, right? You have sensitivity, you have specificity. Now, you also have positive predictive value and negative predictive value. My question to you is, which one of these, group A or group B, is only affected by the reliability of the test? Not by the population, but by the test itself. B. B is the one that's only determining the test. A is showing you how well it is at picking up a positive or a negative. Yes, A is the clinical relevance. Agreed. I completely agree. That's the one that you want to focus on. But what my question is which one of these is just a parameter of the test, not of how well it is? And this is B. Okay? So whenever that's said, that means if you change the population at all, you will never change the sensitivity. You will never change the specificity because these parameters are based on the test. Yes, perfect. The test is the test. It's always, your test is always going to have 40% biochem or 20% GI. Like it's always going to have that same percentages. That is the sensitivity and specificity. Okay. So we mark out A, B, E, and F. So now we're down to C and D. Okay. So what's going on here is that they're saying that they decline in cocaine usage. And now they want to know which one of these is going to be affected. For you to do that, you have to remember the general graph of how this positive predictive value works with prevalence. Because this is essentially saying with decreased prevalence, what's going to happen? Okay, so let's think of this logically. If you have a decrease in the prevalence, are you more likely to find someone negative who's truly negative? Or are you more likely to find someone who's positive who's truly positive? Which one are you most likely to find? Are you most likely to find the other one? Someone who's negative, who's truly negative, or someone who's positive, who's truly positive, if the prevalence has decreased? Yeah, so you're more likely to find a false positive if prevalence decreases. But I'm wondering about a true positive and a true negative. So if prevalence decreases, okay, what this ends up causing is you have a higher probability of having a negative predictive value. The lower the prevalence, you have a higher negative predictive value. The lower the prevalence, the harder it is to find someone who's actually positive. For instance, if you live in a community and there's millions of people in that community, and the percentage of getting HIV is like 0.00001. If you have a patient show up with a positive HIV test, do you think that's really a positive test? No. because the prevalence in your community is so low. So the chances of you getting an actual positive test on someone who's positive is very low. Okay. However, if the prevalence increases in the community, and let's say it's 99% prevalent, if you see someone with a negative test, are you going to say this person doesn't have HIV? Hell no. You're going to be like, most likely he has it because it's 99% that people have HIV in my community despite you getting a negative test. Okay. And that is why, as prevalence increases, negative predictive value decreases while positive predictive value increases. Okay. Any questions on any of that? Yes, it's these signs, but the basis of it is what I just explained to you. All you did, it seemed like all you did was just remember the lines, right? But the basis was what I explained to you, right? If someone who's positive in a community where you know there's no one getting it, you're not going to believe it. Okay. So that's why you have a high negative predictive value in a low prevalent community and a high positive predictive value in a high prevalent community. So the answer ends up being C. Okay. Good. Let's continue. Here's our next one. Give you guys, whenever you're done, we can just answer it and then we'll go on. Let me get some more water while you guys are doing this. All right, let's see here. Okay, so what's going on here in this vignette is they're asking you, okay, what is the most likely to explain what's going on in this image? Okay, so you have to then look at the image and understand what's going on. So in this image, we have mortality in blue, incidence in pink. Now, the incidence looks like it's constantly decreasing. Okay. But it looked initially like mortality was increasing. So it looked like they were dying fairly fast. However, something happened at this point that caused mortality to decrease without changing incidence. Okay? That's essentially what you're doing. You're doing something without changing the incidence. So, with that being said, we start reading these things up. Changes in the age distribution of the population. No, that doesn't make any sense on why this presented here with stomach cancer would have a decrease in mortality as you got older. Yes, perfect. Now, the next thing, improved patient adherence with established treatment regimes. Okay, if you had improved adherence to treatments, that could lead to a decrease in mortality. However, would that also maintain having a decrease in incidence? No, that does not. Okay, which is why that's not the answer either. Now, improvement in chemotherapeutic agents. Once again, this is treating them so they live longer. However, once again, they're not affecting incidence. Improvements in early diagnostic tests. This would increase incidence. What would this do to the prevalence? Yes, it would increase the prevalence, which is not what is shown in this as well, which is why the answer ends up being E. What's essentially happening here is this. You are treating the patients with a primary prevention, so they're not getting the disease, which decreases the incidence. And because they don't get the disease, you decrease the mortality. You decrease the amount of people who die from the disease, which is why you also decrease the prevalence. Yes, perfect. Which is what you see here, which is why the answer is E. Okay? When you give someone a new vaccine or you decrease risk factors, both of these are primary prevention. Can anyone tell me what or can you guys tell me what a secondary prevention is? What's a secondary prevention? Okay, so seat belts. So seat belts is preventing you from getting, but they only really work whenever you have an accident. So yeah, I can agree seat belts. Another thing, so think more medical screening tests. Is secondary prevention because they already have the disease. You're not preventing them from even getting the disease. You're just saying you got the disease and you're detecting it earlier. So that's a secondary prevention. Okay. I don't know what amp is. Amp equals at this. Oh, I don't know. That's confusing. Um. Oh, oh. Okay. 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 So yeah. So that's what secondary prevention is all about. What's tertiary prevention? Give me an example of a tertiary prevention. Primary prevention, vaccines, awareness groups, diabetic management. Yes, perfect. So this is to decrease the complications. Yes, long-term care of the disease. Perfect. They got the disease. We're just trying to make it better for them. Okay? Good. Make sure you remember this equation where prevalence equals duration times incidence. Okay? That's how it's set up with pertaining to prevalence, duration, and incidence. If you ever want to calculate the prevalence, you find out how often are people getting it, how long are they living, and that gives you your prevalence. Here's our next question. I'll give you another. You guys can answer whenever. Okay. So we got a D here. What else? Is that it? Are we good? Okay. So, yeah, great job. This is the right answer. 28 over 40. What is 12 over 40? What would that depict? So this would depict the incidence of not getting sick. Okay. Yes, that's your control. Perfect. Now, my next question is this. What's the relative risk? So give me numbers here. CER divided by EER, I don't know. I mean, that's fair enough. Abbreviations is fair enough. It's not bad. What's the relative risk? So you're saying 12 over 40? No. So essentially what it would be those who got exposed divided by those who did not get exposed. This would equal your relative risk. Okay. Now, with that being said, how would you calculate out your number needed to harm? One minus relative risk? So when you do one minus the relative risk, you're doing a separate equation. Here, let me show you. Let me show you these equations now. Because I don't want you. Oh, I think I already had it over here, actually. With step, tutor, group, and biostats. Where is it? Oh, here, epidemiology. So whenever you look at so we did the relative risk. Exposed divided by unexposed. Right? Yeah, perfect. There you go. So one divided by absolute risk increase or absolute risk reduction, either one of those, that's your actual number needed to harm. Perfect. So this is our relative risk, right? And then if you take the relative risk, let me find it. See, this is great because I have everything on here, but then it's bad whenever I need to find certain things. That's specificity. Where's my number needed to harm? I thought I had that here. No, I don't. That's poopies. Okay, but it's essentially what we're just discussing, right? So that's whenever you look at the increase or the decrease. So you take these two and you minus them. Here, let me find it. Here you go. So you take these two incidences, incidence of E minus incidence of O, and then you divide that by 1 or 1 over X, which is what this answer is. That equals your number needed to harm or number needed to treat. Okay? So that's how this works out. All right? Make sure you're able to work through them. The IO, incidence of the exposed, incidence of the unexposed. You minus them. X would be the value of what these two would be. So for instance, if this was 5 minus 2, then X would have been 3, and then it's 1 over 3. Okay? So that's essentially what this is saying. That's what the X is. Does that make sense? Okay, perfect. Because essentially this is essentially what you're doing. Okay? You're saying the incidence that someone takes this food gets sick minus the incidence that someone doesn't take the food and or eats the food and doesn't get sick. What's the difference between them? Okay? And that difference is what you then do 1 over to find out how many people it will take before you actually get someone sick. That's essentially what you're doing. All right, great. Let's move on. So make sure you know number needing to harm, the relative risk, the incidence, like we just went over. Here's our next question. Yeah, I saw. And I picked that up. Put in your answer whenever you're good. Wish I had more time to talk about biostats because a lot of people just memorize it. But I mean, it's not bad. Okay, so we're saying C. Give you a few more, and then we'll jump into this answer. Okay, let's walk this one through. So essentially what they want you to do is estimate the chance that a donor who tests negative is actually free of infection. So you want to know if I go to the doctor and I say, hey, I got a negative test for HIV. Do I really have HIV? Or is this really negative? That's what I want to know as a patient, right? Good. So the negative predictive value, but not enough time to. No, you have time. So you can make up the time, right? By on the other questions will be shorter and you'll be able to make up the time. But yes, it is a question that you do have to sit down. I do agree 100%. You have to calculate it out. It takes time. It does take time. So I tend to leave these guys for last on the test, right? You skip over them, you mark them, you skip over them, you come back to them later when you actually do have time. and you've done all the other ones, and now it's just these biostat questions. Okay, so with that being said, you look at the question to figure out what the actual findings are. So sensitivity is 95%. Specificity is 90% and is used in a sample of donors in which 10% are known to have hepatitis C. So here's our screening positive and negative from a test. Here's our positive and negative from the actual diagnosis. Since they don't give me actual numbers, I always assume that this is now 100%. 100 people are in this study. That means 10 people are shown up as being positive. Okay? You could do 1,000 if you wanted to. That means 90 people are not hepatitis C. From that, you then multiply it to figure out the corresponding X's and Y's, or ABCs and D's, right? Now, since this is 95, I think I'll make this bigger. So I can make this 95 and 5 and make this number 90 and 810. Okay? Now, from there, you just add across, right? To 185 and 815. And you're looking for the negative predictive value. So 810 divided by 815. The chances I'm negative on the test and truly being negative is 810 divided by 815. Now, what would be the possibility that the test was positive and was actually positive? Just tell me the numbers. You don't have to give me the mathematics. So I used 810 because 90% was the big guy that had to do with, because 90% was the guys that are specificity. So you take 900 and multiply that by 0.9, which equals 90. So then you minus this. Oh, no, it equals 810, my bad. And then you minus that from the other to get the 90. So this 900 times 0.9 equals 810. And you use 810 in the question because this patient's already negative. Okay? If this patient's already negative, you're using these brackets. And then they want to know, if I test negative on the test, am I truly negative? Which is why you move down and they intersect here at 810. So then it's 810 divided by 815. Does that make sense? And that's why you use 810. Now, the question I asked was, if you come to the physician and the test says positive, what's the possibility that you're positive? So you got to break it down into a two-parter. You test positive. So you're using this bracket. Let me erase some of this stuff. You test positive. So you're using this bracket. And you want to know if you're really positive if you test positive on this test. So you're looking for this number divided by 185. This would give you the possibility that you are actually positive when the test comes back positive. Yes, that is essentially the true positives. But this is how they're going to word it, because patients won't come to you and say, what is a true positive? Patients won't come and say, what's the true negatives? They're going to say, my test came back negative. Do I really have this thing? My test came back positive. Do I really have it? That's what they're going to ask. Yes, this is from the clinical level. Like, this is clinical relevance. Yes. Perfect. And in the vignettes that they give you, that's how they're going to do it. Because you should be thinking about these things from a clinical perspective. Okay. Good. Let's think. What else can I say? Yeah, that's about it. Oh, okay, here. I got another question. If this is another thing that they could do, which is clinically based and is using the same mentality. You take this test that you do in Cambodia and you see this kind of sensitivity, this kind of specificity. You then take this test to Africa or Australia, we'll say Australia, and you do the same test. Do you expect to see the same sensitivities? Yes, because sensitivity is based on the test, not the population. If it had said the predictive value, is this test good at predicting this disease in this population that has a different prevalence, then you say no, you cannot depict that because the prevalence is different and the population is different. But you can see what the sensitivity of it is and the specificity of it in your population because it should be the same. Okay. All right. Let's keep moving. So that's why that's F. All right. Woo! That is biostats. I'm going to give you guys some more biostats question in the Socrative tonight for you guys to go through. And you'll start seeing how these guys are worded. They're more worded towards the clinical basis of it. Okay. Now let's look at GI. GI, embryo. This is the first step, embryo. Embryo of GI is pretty straightforward. There's not much going on here when it comes to the GI embryo. You need to be able to break down the GI system into foregut, midgut, and hindgut because they're supplied by different blood vessels. And as a result, they are supplied by different nerves as well. Okay? So, in the foregut, it's a celiac, superior mesenteric, and then inferior mesenteric. Now, what is the cutoff point in the foregut? It says the second part of the duodenum, but what's another name that you could say other than the second part of the duodenum? And it's the cutoff. between foregut and midgut. It's where your pancreas releases secretions. Yes, the ampulla of Vater. Perfect. Some people also say Vader. I guess they love Star Wars. Whichever one you want to go with. But it's that setup. Okay. Now, with the midgut, it's from here all the way to the transverse portion of the large intestines. 2/3 of it. And then finally, the remaining portions is the hindgut. Now, embryo with the esophagus. You have this tracheoesophageal septum that separates the lungs from the esophagus or the pharynx. Okay? This can sometimes remain or not completely fuse together to separate them. As a result, you end up with a tracheoesophageal fistula, which is what you see in this one and in this one. Okay? This is the most common. Proximal atresia, distal tracheoesophageal fistula. Any of the fistulas will have air bubbles in the stomach because air is coming from the lungs, from the trachea, into the stomach, where it should not be. Okay? Good. Now, let's continue. The pancreas is the next thing. The pancreas is formed of what? Mesoderm, endoderm, ectoderm. What is it formed of? What is the pancreas formed of? Meso, ecto, endo? So this is formed of endoderm. Okay, it's part of that pancreatic bud that forms in the mesenteries. Now, you have a ventral and a posterior or dorsal. And what ends up happening is the ventral bud rotates around to fuse with the dorsal pancreatic bud. This is where you can have two embryological abnormalities. One is annular pancreas, where it completely wraps around the duodenum and constricts it. The other is pancreatic divisum, where these guys never fuse together, and you have one main pancreatic duct draining into the minor papilla, and then a minor pancreatic duct draining into the major papilla. Okay? This is also very bad. Now, rotation. The large intestines rotates, or not really large intestines, but the small and large intestines rotates outside of the body. Okay? Essentially, what is happening is your gut tube is like this. It comes out and then comes back in. So the top portion of it is your small intestines. Bottom portion is more large intestine. Okay? Now, it comes out of the body. It rotates 90 degrees. So now small intestines on the right, large intestines on the left. This can then come back into your stomach as malrotation. That presents as small intestines on one side, the right, large intestines on the left. That's a malrotation issue. Okay? But back to this 90 degrees. Okay? Small intestines on the right, large intestines on the left. It rotates another 180 as it's coming in, and it tucks the small intestines inside of the large intestine loop. And that's why you have that presentation as an adult or as a baby who was born. Okay? Now, as this thing is herniated out, it can stay herniated out. That's omphalocele. Or this can come back normally, but the lateral folds don't close completely. That is gastroschisis. That's why gastroschisis does not have an amniotic cover over it, while omphalocele does. Because the omphalocele, the intestines are herniating through the umbilical cord to do this function. So in gastroschisis, what ultimately happened is it went through the umbilical cord, came back normal, but then something else happened with the lateral folds not fully closing. That part of your intestines are outside the body. So which one do you think is more dangerous then? It's omphalocele, because that's the one where you did not actually rotate properly. Gastroschisis is just a closing of the abdominal wall not happening properly. Okay? Now, when you look at anatomy of the intestines entirely, from the esophagus all the way down to the colon, you gotta remember the different layers. You got mucosa, you got submucosa, and muscularis externa. Okay? These are the big layers that you have. Now, you do have an additional layer being the adventitia or serosa, depending on if you have the layer of mesenteries or if you don't have the layer of mesenteries. The other three are more important. Okay? These are the three that you need to make sure you will know now moving forward. And then if you have time, do the little serosa guy. Now, with the mucosa, you have different layers to the mucosa. You have the epithelial layer, the lamina propria, and then finally the muscularis mucosa. The muscularis mucosa separates the mucosal layer from the submucosal. In the submucosal layer, you have a nerve plexus here, which is part of the enteric nerve system. So it deals with just the GI system. Okay? This mucosal nerve plexus is called Meissner's or submucosal. Let me ask you a question. What's the function of this guy? Good. He deals with secretion. He deals with blood supply. Those are the things that the Meissner submucosal plexus does. Okay? Now, the muscularis propria is formed up of two muscle layers, one being longitudinal, one being circular. Okay? Between these, you have the myenteric nerve plexus, also known as Auerbach plexus, which you see here, also known as Auerbach, and this guy deals with propulsion. GI movement peers? Okay. So yeah, so it deals with GI movement. Your autocorrect is really getting you today. But anyways, let's keep moving. So that's how the layers are broken down. As you move from the esophagus to the stomach, you start forming pits. These pits are known as gastric pits. Okay. And then that pit then continues on as a crypt, which then continues on throughout the rest of the colon. You gain pits in the stomach that continue on as crypts. Okay? And in the small intestine, you get villi, which allow you to help with absorption. Any questions about this picture? No. Perfect. Now, make sure you remember what is retroperitoneal and what's not. There's a mnemonic, side puckers. We'll keep moving on. Here is the actual ligament system. I'm going to show you guys what's the more important things in each one of these ligaments. Okay? So, for instance, the gastrosplenic ligament has the tail of the pancreas. Very important. It also has the splenic artery. Okay? Now, the next thing is the hepatoduodenal ligament. This is very important because you have the triad at this location, the portal triad. The last one that's very important is this hepatogastric ligament, because this is what helps separate the greater omentum from the lesser omentum. Okay? Let's keep moving. So, this is the blood supply now. The blood supply of the large intestines and the GI system is basically broken down into three. Just like we discussed, foregut, midgut, hindgut. Foregut, celiac, midgut. Foregut, celiac, midgut, superior mesenteric artery, hindgut, inferior mesenteric artery. Okay? Here is the corresponding blood vessel supply. I'm only going to point out the very big things, which is the anastomosis. Left and right gastric anastomized together, as well as the left and right gastroepiploics. Okay? Now, the last one I want to point out is the pancreaticoduodenal. The superiors, synapse or anastomose, with the inferior pancreaticoduodenals. These guys supply the head of the pancreas as well as the duodenum. So if you damage this artery supply or have to take it out, you also have to take out a portion of the duodenum, because that is where the blood supply is coming from. It's this pancreaticoduodenal artery. Now, there is also a condition where the superior mesenteric artery snatches down on the renal vein. You saw this in endorepro with something called varicocele. Okay? Or nutcracker syndrome, you may have heard it as. Right? Maybe. Okay. So, well, now you know. So moving on, the next thing you have to make sure you know is the differences with the pectinate line. So the pectinate line is the separation between hindgut and the ectoderm of the skin. Okay? There's different nerve supplies for each, as well as artery supplies. So for instance, you get the superior rectal artery and the inferior rectal artery. You get the superior rectal vein and the inferior rectal vein. You even get different lymphatics. Drains into the internal iliac, drains into the superficial inguinal. This is a big location where you get crossover. And they love it as anatomists. Now, here, this is showing you the portal blood flow. Okay? In portal blood flow, this is draining the stomach, large intestines, portions of the rectum. Okay? This drains into the liver, where you detox. So essentially, everything you get through the GI system, through the stomach, the large intestines, first go to the liver to be broken down and stored. There's only a few locations where you bypass the liver. One is the anus, because you also have systemic circulation. Okay? And the other is the mouth, because it's very absorptive in the mouth as well. Here is going a little bit more with the anatomy portions of it. Make sure you remember that there's a cystic artery that supplies the gallbladder. This is a one vessel. So you damage this, you lose the gallbladder. Okay? That's why that's so important. And it's supplied by this hepatic artery, the right hepatic artery, inside this hepatobiliary triangle. This here is the pancreas. We've already touched on what the pancreas is with the main pancreatic duct and the accessory pancreatic duct. You also have the gallbladder here that drains into the common bile duct via the cystic duct. The cystic duct and the common hepatic duct fuse together to form this common bile duct, which is why that drains into that. And lastly, this enters the ampulla of Vater, which then leaves and enters the duodenum. Okay, that's blood flow. That's bile flow. That's pancreatic flow. Any questions about the anatomy before we move on to the physiology? Okay, now physiology-wise, this is going to be the biggie when it comes to GI. They're going to give you some kind of hormone, some kind of neurotransmitter within the stomach or in the duodenum, and then they're going to ask you what cell releases it, or they're going to ask you what is a function, or they're going to ask you what is a secondary messenger. That's where they love to test people. And in all honesty, I don't blame them, because look at it. It's 2 whole pages in your first aid book. Okay? And essentially, it is exactly what I was saying. The source. G cells for gastrin. Somatostatin for D cells. Cholecystokinin for I cells. Secretin, S for S cells. Glucose-dependent insulotropic, I spell it as glucose. dependent. So it's K cells. Motilin is just what it is. VIP is also what it is. Ghrelin and nitric oxide. Some people will go with ghrelin and grelin, however you want to go with it. I've never used that before. But vasoactive intestinal peptide and nitric oxide, these are your relaxers. Okay? They relax muscles in the intestinal wall. This is going to be something that you have to literally sit down and look over these guys, as well as their actions and their regulations, because those are all fair game here. Intrinsic factor. This is big when it comes to B12, right? Gastric acid comes from the parietal cells in the stomach. This all comes from the stomach. Let me show you. Gastric acid. We have pepsin from the chief cells. We have somatostatin with the D cells. This is all stomach. That's another way that you can help condense this stuff down. Well, are we in the stomach? Then we're thinking of gastrin, somatostatin, gastric acid, pepsin. Those are the guys we're thinking of. Even motilin. Excuse me. Even some portions of motilin can come from there, and ghrelin. And then you can think, okay, the duodenum. What's in the duodenum? Okay, well, in the duodenum, we have, again, some D cells. We have some I cells, some S cells. We have some K cells here. Yeah, that's pretty much it. Okay, so that's what you can do to help memorize it. I'm sorry, there's nothing more to it. It's you just got to do it. Here, pertaining to absorption, iron is absorbed in the duodenum, while B9 is absorbed in the jejunum. B12 is absorbed in the ileum with bile salts. Okay? Here is the secretion pathway for how these glands work. I added this in here because of one thing. You can see how there's chloride being secreted into the pancreas, into the salivary glands, into any of those secretory glands you have in your body. This is done by that cystic fibrosis channel, CFTR. So as a result, you lose this in cystic fibrosis. So sodium decreases secretion as well as water decreases, which is why you get very sticky intestinal secretions. Okay? Now, this is the opposite for the skin. In the skin, chloride is absorbed, which allows the sweat to not be so salty. So it's the opposite. Now, this is the pancreas we're now looking at, and its enzymes. The big thing here is enterokinase. This is required in the intestine. You do not have that, none of the other things will happen. You have to have enterokinase. Okay? Here is pertaining to bilirubin and bile. Off to the left, it's showing you the breakdown. So you have RBCs that break down into heme that then get brought into the liver via albumin. It then becomes conjugated via this enzyme, UDP glucuroniltransferase, and is excreted in the bile. That bile then enters the duodenum and gets acted on by bacteria. The bacteria turns this conjugated bilirubin into urobilinogen as well as stercobilin. Urobilinogen gets reabsorbed and you excrete it out as urobilin. Where is this absorption happening? Bless me. Where do you absorb the urobilinogen? The terminal ileum with the bile salts. Okay. All right. So I know the last bits with physiology was a little bit quick because of the time constraints, but I can tell you right now, this is the more important thing, as well as making sure you know how the pancreas works with the enzymes. Outside of that, the physiology. Yeah, so this is this right here is that hepato or enterohepato circulation. That's what this is. Okay. Yep. All right. That's it. I wish you guys the best of luck with your test. I know you guys are going to do well. We've gone through all this stuff very close and in depth. It was quick because we only had 2 hours, but we've touched on all of it. You guys have been doing questions on all the concepts. It's just now applying it on test day. Okay. I have no doubt that you guys will see some questions that we've talked about in concepts because I really, really stressed on the very important ones. And if you have any questions moving forward, tomorrow you have a study day that there's no sessions where you can ask me questions if you want to about anything you run into. I'll personally, I'll write you up a little page on what's going on and send that to you via WhatsApp so you can get your feedback on it, on why, like what's going on here, why is this the answer, why is that the answer, and whatnot. But that's about it. You guys got it. I will send out a just be aware that I may send out a message in WhatsApp a few days after your test to, one, congratulate you guys for taking it, and for two, to tell you guys about a summer course that I'm going to start for people moving from Med 2 into Med 3 to help prepare them for Med 3. Okay? Because Med 3 is a whole nother beast, and you guys will be ready for it when you get there. But it's more of kind of a prepping situation to kind of like help you realize how stressful or how prepared you need to be for Med 3. Okay? Because in Med 3, the pathology comes, the immuno comes, as well as all the stuff you knew before. Okay? So just be aware. I will send that out at a later time. Just focus on your test right now, because that's the most important thing. Okay, guys? All right. Have a great rest of your day. And I hope to hear from you guys later on. Bye, guys.